Tonight we begin a new series, The CEOs. What would happen if two chief executives sat down and shared thoughts with each other on what's driving business decisions in their fields? I've asked Delta Trust CEO French Hill to lead this new initiative. He and Baptist Health CEO Russ Harrington met recently for some smart talk on the current business climate and some healthcare insight.
The first thing that strikes me is there's no better mirror on our national economy and our local economy than Baptist Health for two reasons. One, the subject is healthcare, and two, you're the third largest private employer in the state.
Correct.
Which is exceptional. What's the mood in the executive suite at Baptist Health these days?
Uncertainty. You know, there are a lot of changes going on, French, nationally, but a lot of focus on healthcare reform, and that makes it difficult for us to plan and execute because of the uncertainty. You know, will the healthcare reform law survive the challenges in the Supreme Court? If not, what comes after that? The political scene, what's going to happen there? That will definitely impact it. So we're in a period of great uncertainty. Makes it difficult to plan. However, you can't just do nothing. So we're continuing to focus on the things that we think we need to be focusing on, regardless of what healthcare reform turns out to be, what it looks like. And you just keep doing what you've always done, and you try to position your organization so that you can be flexible with whatever's thrown at you.
Well, clearly, regardless of healthcare reform, this idea of cost reduction and somehow coming up with a more homogeneous way to treat patients with a common diagnosis is a top element. It's in the Healthcare Reform Act, but it's been something that people have talked about for a long time. Is that an area that you guys are working on now at Baptist Health?
Certainly. I would tell you that most providers first are looking at their cost structure and what they can do about that. We've been focusing on that intently for the last couple of years and are making some real progress. We're also having to try to figure out how to integrate physicians into the process, how to come up with partnerships, because we're probably going to be paid together in the future through some sort of bundled payment. So you try to figure out how you can do more of that. We also have to focus on continuing to improve quality and patient safety. That's a big piece of healthcare reform in terms of what they're going to pay for, what the federal government's going to pay for. We're looking at things like continuing to expand our primary care network. We've got to have the physicians to be able to take care of all these additional people who supposedly will be added to the health insurance rolls, meaning our business may pick up. So there are just a number of things that you have to anticipate and try to be ready for, even though you're not sure exactly what the legislation is going to require.
Well, you say you need more physicians in more specialty areas to take care of increased potential volume if they're more insured, but
correct.
There's a shortage now. So how do you see that being reconciled as the baby boomers retire and have more health needs at the end of life? What kind of shortage do we have in Arkansas now?
Well, we have
now before we perhaps cover more people, although I'd argue that maybe they're not being covered, maybe they're not going to require, they'll have more primary care, but they're going to be treated if they need to be treated because we treat everybody.
Absolutely.
Right. So
don't turn anyone away.
So, but it would have more outpatient visits, more primary care visits in theory if somebody were under a plan with more of an oversight process. But
right.
What's our shortage now, and what do you think it's going to be?
First of all, I think it will increase the numbers of patients who will come, even though today we take care of their emergency needs.
Right.
If you're a patient out there or a customer and you have no coverage, you delay. You don't want to come because you know you don't have the money to pay for the care. Mm-hmm. So I think that when people are covered, we'll see a lot more of them coming in, and hopefully they'll come in earlier, because that gives us the opportunity to take care of the health care needs before they become chronic. So that's one part of it. In the specialties, several of our medical specialties have shortages today. In fact, most of them have shortages today, especially neurosurgery, neurology. I could name almost any specialty and tell you if you look to the future 5 years out, we're going to have some severe shortages. But also primary care. Primary care for the last 10 years or so, we're seeing a diminishing number of physicians who go into primary care. That's not a good thing. And so we worry about that. Now, what's the solution? We can't solve it. I don't believe we're going to solve it by adding many more physicians in the pipeline. That doesn't appear to be anything that's going to happen in the near future. Healthcare reform did not do much for that. Your medical schools, they're pretty much maxed out on what they can provide in terms of education and the number of residents that they can produce and pay for, because most of the residencies are paid by the federal government, and those dollars are declining. So I think we have to look for new models of care.
So productivity is the only answer in that scenario.
Well, productivity plus other types of caregivers, your physician's assistants,
right.
Advanced practice nurses, and perhaps some unknown titled allied health professionals that we don't even know about yet. We've got to find other qualified people to help take care of the masses. And the doctors will be taking care of the very sickest. That's the way I think we're going to see it go in the future.
Should we as consumers of healthcare be concerned about that?
I, for one, am concerned, the baby boomer nearing those ages when we're going to need more and more health care, and we have more and more people, a higher percentage of our population having chronic care problems. Yeah, I think we should worry about it.
I mean, it seems to me that while that's efficient and it saves on cost and it may even improve delivery productivity, I mean, can you just have a physician's assistant, reading out of a manual, this is how you're supposed to treat a condition, and not have a 25-year or 30-year veteran physician in the room? I know they would check with them, but that does seem sort of a manufacturing approach to healthcare, which we haven't experienced in our country to date, really.
If it's structured right, it'll work. We have some outlying clinics in rural areas that we primarily staff with advanced practice nurses, but they have a physician nearby at their beck and call, a physician who comes in and reviews everything they've done, signs off on everything. So you could have 3 or 4 nurse practitioners running a clinic with one physician being responsible, and that nearly quadruples the ability to see patients over what he could have seen as a lone physician. We'll see much more of that. It's already growing in our state.
Are you concerned about the approach that the Federal Healthcare Reform Act took vis-a-vis the consumer's involvement? That is, that some people argue that if the consumer had more say, had more skin in the game, using something like a health savings account, that they might be a better, more competitive shopper of healthcare services, while you're working on the cost side, and the combination of those things would really end up with a better financial outcome for the country. What's your view on that?
Well, I think that's a good point, and I think we may see that yet, and I think it could help. What we also need to do, though, is figure out a way to make patients more compliant.
Follow directions.
And then even before that is to get them to live healthier lifestyles. So there's a number of things that should be done and could be done to help the health of our citizenry.
I think people would argue that if one had more skin in the game, then they'd be compelled to a healthier lifestyle because they'd see the impact of it sooner, quicker for themselves. That doesn't sound very compassionate particularly, but it might lead to a better outcome.
Well, I think you're right. I think we have gotten used to the insurance that's very beneficial to us.
Yeah.
And so the more insurance you have, probably the more frequently you're going to go see your health care providers. You're not worried as much about the cost.
Yeah.
If you have more skin in the game, as you termed it, you might think twice before you would rush in to see about a minor health care issue.
Well, in Arkansas, of course, we have a huge rural area, and you solve it and address it with some 175 points of contact around the state, which is remarkable. And yet there's some actions in Congress, I think, that are proposing to cut back some of these rural health delivery systems that actually tried a low-cost way to deliver that simple, basic primary care where we don't have density of physicians.
That's probably the worst place to cut.
And was that part of health reform, or is that an unrelated matter? That
it's more related to the need for reducing the deficit.
Okay.
And the current program that the president has submitted to the Special Committee on Deficit Reduction.
Right.
There seems to be more emphasis on cutting at the rural hospital level and in the rural providers than just recent years, because in recent years, about the only places who've gotten increased funding in healthcare have been rural areas. And now all of a sudden it seems like the emphasis has changed, and the cuts are going to be in those areas as well. And that's not good for our state, and it's not good for the health care of our citizenry.
Right. I would say that would have major deleterious effects in the Midwest, particularly, and it's only through that networking that you can actually get those productivity gains, where you get a physician handoff.
Correct.
To a primary trauma type center and main hospital in a larger metro area.
Correct. And with the financial pressures that come from those kind of cuts, I think we're going to see more and more pressure on small rural hospitals, and I think we're going to see closure of some of those hospitals. And that's going to put a lot of pressure on the people who live out in those areas, and it's going to force more people into the larger facilities like ours and other tertiary
at huge
providers.
Transportation costs and
Exactly.
poor handoffs. There's going to be poor handoffs in that process, and there's going to be unneeded trips. Do you see that hospital groups like Baptist Health will end up absorbing those hospitals, or do you mean the facility itself will be closed and the beds taken out of the system?
There'll be some closures. Now, you're going to continue to see consolidation where it makes sense.
Right.
And where it can be done appropriately and financially viably. But not all of them can be absorbed and taken care of by larger facilities. There's a financial limit on how many of those you can do. We have 3 very good rural hospitals today, and we work really hard and struggle at times to ensure that they remain financially viable. We've had opportunities to take several more, but when you look at them, sometimes you can't figure out a way to make it work financially.
Right.
So we'll see some closures.
Well, you mentioned the Deficit Reduction Act, and you may be a great optimist, but to find the Committee of 12 can successfully come up with a bipartisan solution by mid-November seems a bit of a stretch. So are you fearful that the across-the-board cuts will take place? Of course, Medicaid is off limits for the moment,
right.
And so it's primarily a Medicare 2% cut, which does affect all of our adult hospitals in the state. What are your views there?
Well, first of all, in healthcare, you have to be an optimist. Secondly, as we analyze it, I think I'd rather have the 2% across-the-board cuts.
And just because you can then manage
exactly.
that. If
you know what they're going to be,
right.
You can manage to it. Today, we've already, under the health care reform law, hospital or providers are already scheduled for $155 billion in cuts over the 10 years. These recent recommendations that the president has made to that committee adds another $321 billion on top of the 155. I see no way that we can handle that. So a 2% cut across the board for healthcare providers would be much better than some of the recommendations we think will come out of that committee.
Have you got a plan in place if that's necessary?
We have anticipated the $155 billion cuts would mean that over a 10-year period, we'll lose $138 million. We're not sure how we could make that up. I can tell you we don't have a plan to make up the additional $321 billion that we would get our share of.
Right. When a business person hears that, the first thing I think of is, well, what are the options? And so we can reduce service.
Exactly.
We can reduce payment for the people who work for us on the supply side, or we can raise premiums for or costs of access to the consumer. And just as we sit here today, the Kaiser Foundation has come out with a survey of recent medical insurance premiums, and they were up 9%, which is high. It's not as high as it's been in some years, but it's still a big jump. Are we faced with higher and higher costs of care for consumers, even though the whole debate in Congress, I would say, centered on two things. One, fairness, pre-existing conditions, for example.
Right.
Two, some sort of regular access so that we don't have emergency care use. And three, we were going to lower cost of access and premiums because we're going to spread all these costs over more people. That just doesn't seem to be working out that way. Can you reflect from your real-world experience?
Well, it's really a complex issue.
Yeah.
First of all, costs will continue to go up because of the aging population, because of chronic conditions, just because of the higher level of resource use. But I don't think you're correct when you say premiums will just keep increasing.
Yeah.
I think premiums will be capped. That makes it even more difficult.
By government action?
By government action.
Wow.
So I think that makes it even more complex in terms of how do you solve the problem when you have greater demand, but you have less revenue to take care of the demand.
So out in the nonprofit sector, again, we can cut costs or we can raise philanthropic dollars, even though we're also proposing to eliminate the charitable deduction for certain people at a certain income. Boy, that seems like a train wreck to me.
It will be a train wreck. And unfortunately, too often, we have to have those train wrecks before Congress realizes what they've done and tries to find another fix.
Right. Other people have raised other topics that they say would lead to lower health care costs, such as tort reform. And it seems to be a mantra for some out in the political world. And we've had a modest tort reform here in Arkansas that the bar, the trial bar, and the hospital administrations over the past years have supported. After experiencing that, what do you think about tort reform? Do we really end defensive medicine by capping damages, or will defensive medicine be outlawed by the concept of bundling and checklists for what defines quality care? Reflect on that.
Well, that certainly could have an impact. But no, I don't think you end defensive medicine today as long as the tort reform we had in the past has been good, but it hasn't been far enough, hasn't gone far enough to have a strong impact. So I would hope to see more tort reform, and I think that could be very beneficial. But until we get that, unless there's mandates and caps, you will see physicians continue to practice defensive medicine just out of their own self-preservation. They have to do that, and I wish we could avoid that.
Do you think it's better to handle that in a state-by-state way, or have federal tort-related legislation?
It'd be easier if we had federal. You know, usually you want to think, well, it's better to do it by your state.
Yeah.
But it doesn't appear that that's going to happen to the level that it needs to happen. So a federal law in this case would probably be better.
Let's talk about regulatory burden, which is related to it. It seems like the newspapers are filled with stories about raising taxes or lowering taxes and the tax burden on corporations. And there's very little thoughtful analysis on the cost to the economy of regulation. So as a nonprofit hospital, you're not particularly too concerned about tax policy other than, as I've mentioned, charitable donations. But boy, in healthcare and in banking, we both live with a very regulated environment.
Yeah, I was going to say healthcare is the most regulated environment by the federal government in the country, but I'd probably say next to banking, it's the most regulated.
Well, how many people? This is the old stack of paper question. How many people annually are performing a regulatory review of an aspect of your operation?
Well,
not that it's bad or unneeded. I mean, this is not a judgment point, but there is a point at which it can become counterproductive or interfere with care, interfere with daily operations. So
Well, we start with 130,000 pages of federal regulations that govern the operation of hospital providers. 30 agencies of the federal government regulate hospitals. I don't know about banking, but the 30 separate agencies. Then there's the state.
Yeah.
Then there's the regulatory agency, the agencies that survey us, not the government, but private agencies, like the Joint Commission. All of that is almost at times unlivable, unbearable. Now, we do need regulations. Regulations are needed to help ensure patient safety and quality of care. But when they become overburdensome, when they become
or duplicative or even contradictory between agencies.
Contradictory.
Yeah.
That's when we just get a little concerned.
Right.
And in our organization, we have 2 departments that deal strictly with regulatory affairs. One is our internal audit function.
Right.
There are 5 people in that department. The growing area is compliance. Our compliance department has 6 people in it. Then we have 2 full-time attorneys. All those people are working primarily on laws and regulations promulgated by the federal government under which we live on a daily basis. Some years ago, and I was trying to remember this morning, I think it was about 10 or 15 years ago, we participated in a study with the American Hospital Association, as I recall, about the regulatory environment and the impact it has on the cost of health care. And at that point in time, that was at least 10 years ago, we estimated that we could reduce our rates by 20% if we could just reduce some of the regulations. Not all of them, but some of them. It's much worse today than it was 10 or 15 years ago. I mean, every week we find out about new regulations, something new that causes us to. I've had just recently, both of those departments I just referenced have come in and said, we can't keep up without more people. And I'm saying, but we're trying to reduce the number of people in the overall system. So it's a never-ending struggle just trying to keep up with federal regulations. Just trying to know what they are is a difficult situation.
Yeah, I would love to know, because when you look at 7,800 employees that work for you statewide, the fact that you've got 11 or 15 highly paid, very talented professionals in audit and compliance, that doesn't seem in and of itself, I think if you were being a critical reviewer, wow, that seems very reasonable to me, somebody might say. But they don't look at how that touches every physician, every nurse interaction, every patient interaction. And of course, we want top quality.
Right.
So where there are best practice rules, which used to be set by the industry, now are enforced by some of these organizations. No one's complaining about that.
Right.
But I wonder what the cost per day in your day rate when you try to come up with what you're going to charge per day in the hospital for an overnight stay, how much that's affected by regulatory compliance so that you can get some sort of common sense test. And this is why I think people write about taxes.
Absolutely.
It's so clear. Well, it's my tax rate's too high or it's too low, or if you tweak this, this behavior will change.
Right.
And no one seeks to have that argument about regulatory policy.
I know.
They just let you add one more person and you'll take care of it.
It's because there's so many agencies, so many regulators, so many additional regs coming out constantly that we can't even keep up with them. The general public has no idea how many they are and how much it costs us to just maintain an ability to know what they are and then to try to comply with them.
When you look at 100, I think you said 130,000
pages. Yeah.
Pages. Are they becoming more prescriptive? In other words, we're going to put an armband on a patient and we're going to ask them 3 times and we're going to ask their guardian 4 times, again, which is a patient safety issue. And so that one we might have been proven hospital by hospital is an absolute way to assure that the drug being administered is right. But do you find that concept is being carried out into just all kinds of other areas, and so there's just no judgment left for the...
It's exploding into all areas. just more and more and more of that. We have to verify the credentials of all 7,000 of the employees every year, and then we have to review every vendor, and that now numbers about 7,000. Every vendor every year to determine that they don't have any issues with the federal government. Well, that's a burden that's been placed on us by the federal government. They didn't want to do that job, so they placed it on us as a mandate.
Right.
We have to do it. And that's just one example of how that's exploded over the years.
Let's take a minute and talk about your views as a business person to barriers to employment. We've talked about healthcare reform is producing uncertainty, so it's real hard to judge, and then the burden of regulation. What other barriers do you see to greater employment in the country?
I think the biggest barrier is the uncertainty. I would be highly reluctant today to go out and start a new service and hire the new people to provide that service. We're trying to maintain the services that we have, keep the high-quality people in the jobs that we have, but we're also looking for ways to reduce the numbers, become more efficient. We're not looking to add people or add services, go out and build a new healthcare delivery facility. Just too much uncertainty to do that. That's in our business, and that's true, I think, in every business, especially out in the private sector. If they don't feel comfortable that they can recover the cost of doing the new service or the building or adding the people, why would they do that?
Well, you've got plans, you do have plans to move west. I feel like Horace Greeley must be in Little Rock because both UAMS and St. Vincent's have both announced campus additions strategically out west, and Baptist Health as well. Tell us about what your plans are.
Well, it's to just be real honest with you, we don't have any definitive plans. We'd looked out west for the last 4 or 5 years, and we never found a site that really intrigued us in terms of being able to provide primarily outpatient services. But this site became available 2 years ago. We looked at it and backed away. A year ago we looked at it and decided it would make sense. It would be an ideal location for a satellite facility. And even if we never develop plans to utilize it, it can't be a bad deal real estate-wise. So we went ahead and made the investment, and we are beginning to think about what would be the best service to meet the need of the people in that community. And the land is large enough. If we wanted a small hospital, we could do that. But that's not our primary approach. It's probably a system of outpatient facilities that are needed by residents of that community. And we haven't done our studies to determine those needs, but we'll be doing that, I'd say, over the next 4 or 5 years.
And you said you were an optimist to be in healthcare, and you've got a capital campaign on your calendar for the upcoming years, $110 million.
Must be optimistic for that.
Got to be optimistic. And is that here on campus at Baptist Health, the majority of those
Yes, sir.
funds?
Just this facility. Our hospital here is we just had our 37th birthday. It needs some updating. We've never had all private rooms. We're now the only hospital in Little Rock that doesn't have all private rooms. That puts us at a competitive disadvantage. We're working on that, and we're making progress. We have many more private rooms today than we had 3 years ago. But we can't get all private rooms without this program that we've defined as our capital campaign. As you may remember, we purchased the Southwest Hospital a few years ago. That gives us the ability to move some services from this facility out there and then renovate. But first we have to do some renovation there. Then we move everything off one level to this facility. And with that and the refurbishing of those units, we will have enough space for all private rooms here. So that's a big piece of that project. The other large piece of it is the total renovation of all of our operating suites. When we opened 37 years ago, we had state-of-the-art facilities, great operating suites, large enough we thought would last forever. Today, some of our operating rooms are small enough that we can't get all the innovative equipment that we have in the rooms and give adequate space for the surgeons to utilize the equipment. So we have some internal space to make the expansion with the renovation that we have to do, and that's a big piece of that that project. It's necessary just to be able to recruit qualified surgeons that are coming out of training programs today where they've had large
Sure.
rooms and all the equipment, and they expect that when they come to a private hospital like ours.
Well, I know you'll do it. You've got a great track record at capital raises
Well.
here at Baptist campus. And what led you to healthcare as a career?
I saw it as a ministry. I'm the son of a minister, and I always admired and respected my father for his ministry, and gave me the desire to want to be in ministry, but I didn't want to do it the way he did it. And then the military put me in healthcare, and it dawned on me as I was fulfilling my military obligation, you could marry those two. You could marry healthcare and ministry and do something really good with it and feel good about it. And I've been privileged to be here now 38 years at Baptist Health, and we've married those two, ministry and healthcare.